Hi, today we're going to talk about our concept of perfusion with the exemplar and topic of arterial lines and pulmonary artery catheters. We are going to be doing some more invasive hemodynamic monitoring on our critically ill patients, and this is to help us have early identification and treatment for them for any rapid deterioration. It's going to help us assess the level of shock and to help understand their cardiac and pulmonary status and help with real-time complications and immediate interventions. So with our critically ill patient, we want to be able to evaluate their immediate response to treatment, especially when they are on IV medications that are controlling their heart rate or their blood pressure, or even our patients with mechanical ventilation support. We will have them usually on also non-invasive measurements such as a heart rate, a blood pressure, an oxygen saturation. But with advanced technology, we're now able to use more invasive monitorings. We're able to have an insertion of a catheter that has a sensor or a collection device into the heart that's going to give us more data points and give us real-time monitoring for these unstable patients. Now, even though this provides us with better data, there are still a lot of risks associated with it, such as infection or potential injury to the vessel walls or the cardiopulmonary anatomy, which we'll talk about. And we also want to make sure we discuss the different types of measurements that we're going to be seeing. These will be shown as waveforms on a cardiac monitor and how we're looking at them, and the importance of a proper setup to ensure that we are getting accurate data with this. So one of the things that we're going to be looking at with this monitoring is our cardiac output. So we talked about this with cardiomyopathy, where our cardiac output is our heart rate times our stroke volume. Heart rate is affected versus high or low. Our stroke volume can be affected by the preload, afterload, or contractility, and with our ejection fraction. And we're going to talk a little more in depth about that. So here is just the formulation for cardiac output, which is what we talked about. It's our stroke volume times our heart rate, and then what we see that is affected with that. Typically, the normal cardiac output is about 4 to 8 liters per minute, or an average of 5 liters, with an average of 5 liters per minute. So let's break it down a little bit more. When we talk about stroke volume is the amount of blood ejected with each ventricular contraction. Okay, so this is influenced by your preload, your afterload, and your contractility. The average stroke volume is about 70 mLs per beat, and we want to think about the different types of things that are affecting it now. So your preload, your afterload, and your contractility. So let's break down a little bit more into that. Your preload. So preload is the amount of blood in the ventricles at the end of diastole. So it's defined as the force that stretches that ventricles during diastole and the amount of volume that's in there. So generally we know that the more the myofibrils are stretched, the greater the force of the contraction. That's Starling's law. So kind of think about it as a rubber band. The more you stretch it, the harder it's going to pop. But however, the amount of stretch in those ventricles is also determined by the amount of blood that's returning to the heart. And over time, such as with cardiomyopathy, that stretch can become limiting to the heart being able to have a forceful contraction. Preload is generally measured as what's called CVP, and that is indicative of the right atrium. It's a reflection of the patient's fluid status, kind of known as the filling pressures. Okay, so patients that have chronic renal disease, such as CHF, will have a higher preload because they have cardiomyopathy. They have a generally more volume that sits in that right atrium. And then also the same thing with patients that have vasoconstriction or chronic hypertension. It causes an increased venous return and an increased preload, again, which we see in cardiomyopathy. Things that we might see a lower preload in or a lower CVP would be patients that are volume depleted. So think about patients that are dehydrated or possibly a burn patient that would have that massive dehydration. So afterload. Afterload is defined as the pressure that the ventricles must overcome to open the aortic and the pulmonic valves and to help pump the blood out of the heart. So think about the exertion that is required to open a door against a strong wind. Okay? When we're looking at the right ventricle, that's having to go against that pulmonic valves. The left ventricle is having to go against the aortic valves. Okay? For the left ventricle, we talk about systemic vascular resistance, or SVR. This is high typically in a patient that has hypertension. For the right ventricle, we're concerned with pulmonary vascular resistance, or PVR. And this is another example is a patient with COPD that has restrictions to those arterial system and those valves that cause it to have a harder time opening up. Sorry, my mouse does not like to play. And then we look at contractility. So contractility is defined as the inherent capability of the myocardium to increase the extent and the force of the muscle fiber, shortening independent of preload or afterload. The sympathetic nervous system can positively affect the contractility. It'll increase it. And then there's medications that we can give that will help affect it and decrease that contractility. We measure the contractility as the pulmonary artery wedge pressure, or the occluded pressure, which is seen in the left ventricle. And again, it's that force of the mechanical contraction to get the blood volume out into the body. Okay. Poor contractility decrease is the forward flow, and it will increase the ventricular pressures from accumulation of that blood volume, and it can reduce cardiac output when it is negatively affected. Your ejection fraction. So this is defined as the percentage of the end diastolic volume that is ejected from the heart with each stroke or each beat. Typically, a normal ejection fraction, or EF, is 55 to 75% of that end diastolic volume. Anything lower than that is going to show weakness to those muscle fibers and that contraction. And anything lower than 30%, you have a patient that is at high risk for ventricular dysrhythmias that can be life-threatening. We are able to estimate the ejection fraction by doing echoes or by measuring by a right heart catheterization. And then the other variability that affects our cardiac output is our heart rate. So that's the other determinant of that cardiac output, even though it doesn't really affect stroke volume with the other components. An increased heart rate will help with the cardiac output if your stroke volume is stable, meaning that if you have a fall in your stroke volume, say maybe your cardiac output is not adequate, for a time your body will compensate by increasing the heart rate to try to compensate and create that same balance for the cardiac output. So how are we going to measure this type of measuring? We're going to have 3 different types we'll talk about: a central venous catheter, a pulmonary artery catheter, and an arterial line catheter. The hemodynamic refers to just a line that we are going to be inserting into the vessel that usually measures from the heart. It's going to help identify with hypoxia, volume status, and we're going to be looking at right and left-sided heart failures. With the arterial lines, we're able to get measurements of oxygenation. We can give medications through some of these and do blood sampling through them. And we'll talk about each one. So your central venous catheter is what is going to help us measure our central venous pressures. So typically we see this as a central line. So a central venous catheter is just a big name for your central line. The measurements are going to reflect the pressures of the right atrium, which is our CVP. It's going to give us information about pressure changes of that right ventricle, and we're going to measure that from the distal port of our catheter. And typically the distal port is usually marked, and that's usually the brown port there that we see. So your central venous pressure, CVP, is an indicant of your pump failure or decreased contractility. So pulmonary disorders that can cause a high CVP, we're talking about cardiomyopathy, heart failure, and this is when your patient is in a fluid overload. So the treatment to this is to either limit your fluids, have a fluid restriction, or give some type of diuretics to help pull that extra fluid off. A low CVP reading is usually indicative of inadequate volume. So this is a patient that is hypovolemic due to something going on with them. Is it from a burn and they have third spacing volume depletion? Is it from a trauma and they've had bleeding? Is it from just being ill and septic and dehydration? So our treatment for this is going to be fluid replacement, either with IV fluids or by blood products. And then the next thing we're going to talk about is our pulmonary artery catheter. It is similar to your CVP, other than it's a little bit fancier. It has a little bit more measurements that we're going to do with that. So your pulmonary artery catheter is able to measure your CVP. It is able to measure pulmonary hypertension and look at that right heart function. And if you want to go back to your slides and look at this YouTube video, it's going to give you a little more information about how it goes through. But typically, most patients know this pulmonary artery catheter known as a Swan's GAN catheter. It's a flexible balloon-tipped catheter that is guided through the right side of the heart. Here's a picture of it here. So we guide it in through either the subclavian or the jugular vein. It goes into the right side of the heart, into the right atrium, and then the right ventricle, and then it follows up into the pulmonary artery. This is done under sterile conditions, usually in a critical care setting or under fluoroscopy, because again, we have complications. They're inserting a needle. There's possible complication of hitting the lungs. And then with guiding this catheter through that, you want to make sure you're doing it under x-ray or fluoroscopy because you don't want to damage any of those arteries or valves as you're going through it. It's going to help measure your pulmonary artery pressures, which is your right atrial pressure, your CVP, and that's taken at that number 1 as you see in your picture. And then as it goes into the right ventricle and goes up into the pulmonary artery, we're going to be able to get the reflection of the left ventricle. So as it has gone up into that pulmonary artery, we blow up a balloon, as you see here in the picture. It is blown up, and that causes the pulmonary artery wedge pressure. I think your book also calls it the pulmonary artery occluding pressure. That balloon is only going to be blown up for a few seconds at a time. And what that is an indirect measurement to reflect the left ventricle function. So your left ventricle function is looking at your left ventricular preload, okay, or the contractility. So the different measurements that we're looking at, again, is going in initially to that right atrium, getting your CVP. And then as it goes up into the pulmonary artery, we can get the pulmonary artery pressure, which is indicative of your afterload. And then when we blow that balloon up, we get the left ventricular pressures, which is your left ventricular afterload. And then, of course, that's going to be your contractility of pushing out to the body. And then we're going to be able to tell if our patient's in overload. Do we need diuretics, or if are they underdepleted? Do we need to give them extra fluids? So this is just a picture showing you kind of what you would be seeing on the measurements if you were doing this, say, in a catheter as you're looking at it. So as the pulmonary artery catheter goes into your right atrium, you're going to see your CVP. So CVP, again, that's your filling pressures, your preload, right atrium. Those measurements is anywhere between 2 and 6. As you get into the right ventricle, you see a different waveform that goes up. As you get into your pulmonary artery, that is your pulmonary artery pressure, and that range is typically anywhere between 25/10. And then as we blow that balloon up and we occlude that pulmonary artery, we have pressures that are anywhere between 8 and 12. So when we're looking at these pressures and doing this type of setting, we want to make sure that we are monitoring for any complications such as arrhythmia as we're floating this catheter through the heart. We want to monitor for any bleeding or any respiratory distress because, again, any of the risks include infection, pulmonary artery rupture, the arrhythmias, possible thrombosis, or an air embolism. This is just another picture showing how that catheter is floated through and at different sites where we would be measuring oxygen saturation. This is just a little review that pulls them out all together against your preload, your afterload, and your contractility, which is all of the things that affect your stroke volume, and kind of puts it out between is if you're looking at increased preload, what could be causing it versus decreased preload, same for the afterload and the contractility. This picture here is talking about your phlebostatic axis. So this is where we're looking at a arterial line with this picture, but we're also doing this as far as with our Swan scans, with our arterial pressures. We want to make sure how we are setting them up. So you're going to have a pressure bag that is attached to a transducer that has an automatic flushing line. And then that transducer hooks into our pressure line, which then sends that waveform, that rhythm that we're looking at to our monitor. When we talk about a phlebostatic axis, that is your mid-axillary line. It's at the midpoint of the left atrium and the fourth intercostal space, and that is kind of right mid-center of the heart so that we know we are accurate at that. We're going to be looking at our waveforms to ensure accuracy. The next slide here is kind of talks about that waveform. So our waveforms should be nice and straight across. As you see in this first picture, we have a nice even waveform. It has that little notch, which we call the dichrotic notch. We want to see that. That is giving us a nice even waveform with that. When we have, it shows on a couple of the other ones, when we have a dampened waveform, it is very low. We don't have that dichrotic notch. If it's over dampened, you have a very sharp point. You're not getting that nice rounded points that we're seeing. And when we have these dampened waveforms, we know that there's something wrong when we don't have that dichrotic notch. So we're going to start looking at catheter occlusion. Is it kinked? Is there a clot? Is there air in the tubing? We're going to make sure that our pressure bag is inflated, that our transducer is level and possibly re-zeroed. We're going to look at our pressure cables, make sure that they have good connections with them. And we might need to zero it back to the atmospheric pressure. And we will talk about this during our labs and show you a little more on how to do this on the person at the bedside with the monitors. So the arterial line is the last one that we're going to talk about. Arterial line is different than your central venous pressure line or your pulmonary artery line. is this one is going into the arterial line. The others are inserted into a vein, where this one is into the arterial line. It is nice to have a direct measurement of blood pressures and your map pressures. So think about your patients that are septic. We always want to make sure we have a map above 65. So this is real-time measuring and monitoring of that map. And it's also available for arterial blood gases or blood sampling. Typical insertion sites are going to be at the radial, brachial, or even femoral arteries. Radial is typically preferred due to accessibility and lower complication risks. When we're at that femoral line, we have a higher risk for infection due to the area. We want to make sure that those sites are clean and dry. Before we put an arterial line in, we're going to do an Allen's test, which we're looking at that radial artery to make sure there's adequate blood flow before we are going to be occluding one side. And again, we'll show you that in our labs. We're going to again monitor for signs of infection, for bleeding, for hematoma at the site. Monitor our 5 Ps, especially when we're occluding an artery. We want to make sure our pulse, pain, pallor, paresthesia, or paralysis. And if there's any disconnect or damage to it, patients can bleed quickly because it is an artery, so we want to make sure that we're monitoring those pretty quick. An arterial line is also one that it is just for monitoring only and blood collection only. We do not want to draw any or infuse any type of medication through this port. And if once removed, we're going to hold pressure possibly up to 5 minutes to make sure we have adequate hemostasis. So from here out, there's just a couple questions for knowledge check. So we want to look at when we're looking at our hemodynamic pressures and we're measuring. So remember we talked about our Swan's GAN catheter. We're going to be looking at preload, afterload, and contractility. So when we're looking at systemic vascular resistance, is this preload, afterload, or contractility? When we're looking at peripheral vascular resistance, is this preload, afterload, or contractility? What are we looking at when we're measuring our CVP? And what are we looking at when we're measuring pulmonary artery ridge pressure or our pulmonary artery occlusion pressure? All right, if you were able to guess your systemic vascular resistance and your peripheral vascular resistance, we're measuring the afterload. You were correct. With your CVP, we are measuring our right preload. You were correct. And for the pulmonary artery wedge pressure, we're measuring that left side ventricle preload and our contractility. Here's another knowledge check. If a nurse receives an order to administer 9% sodium chloride IV at 50 mL per hour, which line can be used for this administration? Select all that apply. The peripheral IV, the arterial line, the proximal CVP lumen of the PA catheter, or the distal lumen of the PA catheter. Again, my mouse. If you chose the peripheral IV and the proximal CVP lumen of the PA catheter, you are correct. Remember,